Thank you, Carolyn and Jen, for your fantastic presentation. It's never a pathology presentation without images of food, and your presentation was no exception. I think you should be expecting lots of boxes of chocolates and friend requests tomorrow, because clearly the days of simple synoptic reports are over and we need to be best friends with our molecular pathologists. We're going to move to a more clinically oriented presentation now. We have the pleasure of introducing Associate Professor Malinda Itchins. Mal is a thoracic medical oncologist at Chris O'Brien Lifehouse and Royal North Shore Hospital in Sydney. She is also involved with the thoracic interest group at COSA, as well as chairing the non-small cell lung cancer interest group in TOGA, and is an active clinical trialist and translational researcher. And today Mal's going to talk to us about translating all of these results into real world treatment decisions. Thanks, Mal.
Thank you, Ben. Tad intimidated following the pathologists for this webinar, but we'll give it our best crack. I was just sitting here thinking, what are we as oncologists? Maybe downstream proteins, maybe passenger mutations, but I guess from what we've heard thus far, hopefully we're all feeling a little bit less Mr. Bean-like with how we're looking at our pathology reports. I think I certainly am. As obviously in the clinic, we've got that sort of, 20-minute period to work out if someone best managed it on a targeted therapy or an immunotherapy is the first port of call, really, in the way that we're treating certainly non-small cell lung cancer. Because I think we know, this is an old slide now, but also from the Memorial Group, we saw some data from Stephen on the advantage from this series in RNA sequencing. But actually, if you do proper molecular profiling in non-small cell lung cancer now, really the pie is pretty filled in, and we've got a plethora of targeted therapies that are highly impactful now. So it's a no-brainer. And then, as we've heard, the co-mutational landscape is getting more and more interesting, both from the outset as well as at the emergence, of course, of resistance. I didn't put red boxes around, sorry, we don't have a mouse, and it's because you can see our scanners from our electronic medical records are just great. They're all on a slant, which makes it even more of a joy for us to look at our reports. But I guess as a medical oncologist, I mean, histopathology is still super important, not always easy, but I think I'm always looking at that first, of course. And then what else are we looking at as a, as a medical oncologist? Who is the pathologist? We've heard that. We need to be better friends than ever. Was there adequate DNA and RNA sequencing? What was the quality of the sample? That generally comes up there in that first preamble. We're usually dealing with cytology, aren't we, in lung cancer? What a joy. But generally, if there's been, first of all, a potential driver mutation that has been reported, given that they're often, not always, mutually exclusive, that gives us some confidence in the panel. But it's all the ones we're worried about, the false negatives that we heard about that, really make us scratch our heads. So sometimes we are seeing a DNA sort of readout, but not RNA. So we've got to check that. The tiers of the variants has been so nicely described, and I still always do look at tier 2, and I think as medical oncologists we do want to be seeing tier 3 for those that are able to be releasing these reports. And then I guess we try and have our bit of an educated look at what the variant allelic frequency is, what's the coverage, like how likely is this going to be the report that is the most reliable for our person. So because it's really important that we get it right. We need to be hypervigilant, like my favourite animal, the meerkat. So we need the clinical context, of course, the background of the individual. And there's often, usually, I feel like it's a race when we meet people. There's an urgency to start treatment. So we can only get so fancy, based on how long that person needs to wait to start, or can wait to start treatment. And we know a lot of clinical trials require, patients in the first line setting to be treatment naive, but sometimes we need to bridge with some therapy. And of course, we're thinking about, are these results reliable? Is there potential even of false positives? I think they're relatively rare, but I've got a couple of cases I'll touch on in that domain. Of course, we're always thinking who may need more tissue. Perhaps 30% of people we're looking after really could benefit or may need another tissue biopsy. Liquid biopsy, really importantly, can have advantages in this space. So this is a series of 500 cases published a couple of years ago, and we know the first treatment is the most impactful. And actually, if you pivot to a targeted therapy later in the red line, even though you're going on to a targeted therapy, you never get that survival up where you get it, if you get on the most impactful targeted therapy up front. So Stephen has shown we now have from the RCPA and TOGA group a lovely Australian focused molecular testing guideline. And this has also pivoted off since 2023. We've thankfully had Medicare reimbursement for the panel we need in lung cancer, which is usually around town, still a highly clinically relevant hotspot panel, but very importantly, reimbursed for both DNA and RNA sequencing. So I think that's what we really need to be all receiving. And I'm not sure everybody is still in the clinic. So thankfully, we have been doing pretty well in keeping pace in Australia for our targeted therapies, and the timeline I haven't got time to go through in detail, but from biomarker discovery there in the circles through to getting targeted therapies. Just to briefly touch on it, we've had osimertinib for EGFR now as our gold standard since 2021 first line. We've had a positive PBAC recommendation last week for amivantamab and chemotherapy in the later line, second line setting. We've also got ami-chemo, of course, for EGFR exon 20s, which are a different EGFR variant. ALK, we've got lorlatinib, thankfully, for the last few years. ROS1, we've just gotten repotrectinib, which has changed the game for ROS1. Late last year, we got dabrafenib and trametinib for BRAF V600E, and encobini is coming. We've had tepotinib for a few years now for the MET exon 14 skips, selpercatinib since early last year for RET. We've got larotrectinib for the elusive NTRK. NRG1 fusions to follow, and KRAS is a very busy space, as is HER2, and I think we'll have hopefully a couple coming in there, maybe in early 2028. Because the FDA landscape is even busier, and thankfully busy in a really good way. So the ones that I haven't mentioned in the Australian setting is the AMI laser first line for EGFR in the US. Neladalkib for ALK has had FDA breakthrough designation, as has zidesamtinib for ROS1, looking really hot for both of those important fusions. We heard from Stephen about the MET IHC space, which is not necessarily a molecular assay, but Taliso-V is a MET ADC. What else can we talk about here? The drug for NRG1, I still can't pronounce. I'm happy to pronounce it when we can access it. And KRAS, G12, C inhibitors, so alomarasib, calderasib, MK1084, looking really good. Zoldonrasib for KRAS G12D, zongertinib for HER2, trastuzumab, deruxtecan, of course. So we got drugs, so we got to get our testing right. Because actually we meet people as well, and we can never overcome the performance status we meet when they start therapy. So turnaround time is imperative. So, you know, we see a lot of people, unfortunately, young, who are well, who have compensated, and their tipping point comes and we're meeting them in ICU. And thankfully that ALK IHC antibody is reliable, as we saw, but not everybody has ALK. Because I think once we start targeted therapy, yes, it works, but we never really bring those with low performance status up to the levels of those if we're diagnosing earlier. So turnaround time is so important. People that have, you know, a high burden of disease, losing weight, certainly CNS disease, unfortunately, we're not seeing the survival curves sitting on top of each other. So false negatives we've spoken about. False positives, maybe I won't elaborate on too much because it's a little bit outside my lane and I don't want to, again, offend our pathology colleagues. But I think we've heard false negatives, low-level cellularity. You know, we know liquid can be really important, but there's about a 30%, you know, false negative potential because of shedding, CNS predominant disease, or lower volume or indolent tumours. But of course, it's the quality of the sample. A lot of lung cancers are necrotic. And intratumoral heterogeneity, of course, is a lung cancer problem inherent forever. The quality of the DNA and bone. So we try not to biopsy bone, of course, because of the decalcification process, and I think it rogers the DNA a bit, but sometimes we need to biopsy bone. False positives, I guess. I'm going to speak a little bit on, you know, the potential for calling subclonal variants and them being reported out as the driver and what that means for us in the clinic. Hopefully we're not mixing up samples. I mean, that's one of the ones that came up when I checked, but we'd never do that in Australia. So, you know, first question, should all oncogenes have targeted therapy up front? Well, yes, but I guess the KRAS, particularly G12C space, has really shown immunotherapy is important for that population. So, of course, what's happening, our later generation KRAS G12C drugs in particular are being combined first line, and I'm pretty certain the olomarasib and the calderasib candidate studies are really probably going to be game changing. I think we all can see. The BRAF V600E and MET exon 14 skips are an interesting space. You know, they're rare enough not to have head-to-head data. I think immunotherapy can still be effective in this population. I think perhaps MET tepotinib is still the more reliable frontline agent, but I think certainly the jury is a little bit out there still, and immunotherapy can be important to sequence. So we heard that, yes, TP53, unfortunately. So I've been talking to date about predictive biomarkers, our oncogene drivers, the therapies that we can implement. But then there is the prognostic molecular information we're getting. And like anything, you know, the optimistic lung cancer doctor says, well, maybe that negative prognostic will soon become a predictive biomarker for response. So at ELCC, which I sadly was not at, we recently saw the top data, which is basically looking at, so TP53 co-mutant EGFR cases. So sadly in the oncogene population, even up to 50% will harbour a TP53 tumour suppressor loss of function mutation, sitting at tier 2, I think we heard from the outset, and we know they consistently do not have the same survival. So this is a really important phase 3 trial out of China, which is shown nicely here, and you can see compelling hazard ratios around the 0.5 level. That adding chemo up front for this population and intensifying therapy, I think really is that now where the game is at, and we've been seeing that from subgroup analyses from FLAURA 2. The difficult thing is in the rarer oncogenes, we're never going to see these data in the ALKs, in the RETs, in the ROS1s, and I do think it's important. We then, in some assays, but not all, get the SDK11 KEAP1. We've been hearing about it for years. Cold tumor, but not great. Immunotherapy, not as effective. Poor prognostic marker, basically. We've seen similar that immunotherapy may not be as active in KRAS, and a number of companies have pursued particularly that population more for the targeted therapy. We saw some Checkmate 9LA dual inhibition data that were interesting in small numbers, saying, well, maybe adding CTLA4 inhibition to PD-1 might help in this particular high-risk group, which is certainly unmet need. Now, if we flip over to page 3 of our reports, many of us are using Oncomine Precision Assay, the amplicon-based assay, which treats as well, and I think we heard turnaround time can be kind. I don't think we're getting the data there right now. Maybe that's a good thing. I mean, there's only so much information we can take on, but many of us might not be getting this in our routine panels as yet. And then MTAP loss, our old friend. So I think this used to be tier 3, right? And then it's now it's becoming tier 1. And we're seeing actually now with more sort of broader panels, actually, unfortunately, in non-small cell lung cancer, about a quarter of patients will have what we're calling, MTAP loss, which is basically where we can get a glimpse of whether it may be occurring if CDKN2A is deleted. That's not perfect, but about 90% of the time that means that person may have, or the cancer may have MTAP loss. And so this is a really important pathway that leads to the accumulation of the MTA metabolite. And basically, well, why do we care now? I mean, I think in the clinic, it's because there are drugs that work, including PMRT5 inhibitors. And also because we're seeing this group, which is a big group, really. Unfortunately, immunotherapy is perhaps not as durable. And actually targeted therapy, may not be as durable in those that harbour MTAP loss. And I think there's a real, we're seeing combination trials coming through now. I'm not sure that there are TKI MTAP inhibitor studies, but I think that would be an obvious future development. So in the second part of my talk, I'm just going to take us through a Cook's tour of some cases. That's actual footage of me after the clinic for some of these, as not everything is what it seems. So I'll just start with this uplifting PET scan of a man we met on the ward with spinal cord compression and melena. So that's not good. So we didn't have a whole lot of time, but thankfully we did ascertain a biopsy and result in a reasonable amount of time. He was getting attention otherwise, of course. But, I said mutually exclusive, these oncogenes, but not always. So this chap's had both a KRAS G12V mutation, oncogenic, as well as a MET exon 14 skip. I put this case up as well as I think we did hear prior that MET exon 14 skips, they can be missed on DNA panel in about, we always say a third of the time, but I feel like it is about a third of the time. But this one, wasn't detected on the DNA panel for this man, but was on the RNA sequencing. And then, we scratch our heads, what do we do? I mean, we don't have a KRAS G12V drug widely available, and he's going to be excluded from trials now, isn't he? So he's a victim of the good sequencing because you can't really have multiple variants for, well, certainly the pan-RAS studies. But anyway, he had sort of a cancer that seems immunotherapy responsive, and so that was the obvious first option. And I think in the future, rebiopsy for him will be important. Hopefully we get to that place, but he is responding on chemo IO. So this is another man I met a few years ago. So when we just had DNA sequencing, so that's the caveat. But he was young, and when we see that scan, that's oncogene until proven otherwise, or maybe TB. So he unfortunately had diplopia and leptomeningeal disease, and he was not well, but certainly a phenotype enriched for an oncogene. We got the biopsy. Oh, we're seeing that unreliable ROS1 IHC3+. Woohoo! However, the fish was negative. So thank you, not very sensitive IHC, because we were starting to think, okay, this makes total sense. So then we get our DNA panel, TP53, boo. So time is really important for this chap, however. We had the BFAST trial at the time, which was a liquid sort of first assay, and unexpectedly he came back with an EGFR exon 19 deletion. We also screened him for the aspiration trial, and that is a busy molecular report there, but the first variant is the EGFR exon 19 concordant as well. And actually, when we looked back, it seemed that the panel at that time, the reporting platform or the bioinformatics hadn't registered that particular exon 19 variant as a canonical or a clinically actionable one. So that went back and it was looked at, and it was sort of updated on our reporting panel. So, you don't want to learn this way, but you learn. And again, busy report there, but you can see the MTAP loss and a few other things I've spoken about. But it was really important for this man. He avoided whole brain radiation. He had osimertinib. He had double dose osimertinib. He had some off-label things. He lived a couple of years, with, of course, young children. And that was good considering how things were looking at the start, and we were lining up in Power 150 protocol. Got to put this one in the show bag. NTRK happens. But then sometimes people find out and they don't want the treatment, which is always a joy. But this was one where our pathologist kind of leaned in and said, it's a mucinous, poorly differentiated adenocarcinoma, got on the phone, said, I might do an NTRK IHC antibody, which also doesn't sound completely reliable, but if it's real, it's probably real. And at that time, then we went ahead with our own NGS panel and picked up an NTRK fusion, and then sent on to a clinical trial. And I saw some various letters coming back saying, I think she maybe pulled the pin. But NTRK fusions, we heard, but they're really long sort of fusions, very heterogeneous. And for the tiling and the sophisticated things that we heard about earlier, they can be missed. I think that they can be tricky and they're already rare. So something to think about. So I mentioned I've got a couple of subclonals, just because, is it truly subclonal? Well, I guess was the report the true reflection of the biology, a couple of cases, because they're the ones I actually lose sleep over. And I guess we image early also to see, is everything concordant with what we saw in that initial molecular report? This is a lady I met last year. She was 56, cough, necrotic upper lobe, primary, and small brain mets asymptomatic on MR. Never smoked. Got the report back pretty swiftly. ALK fusion detected. Great. Made sense. Started lorlatinib. She did a copious amount of research. She came back about 6 weeks later, just before Christmas. She's got over 30 brain mets. Makes no sense. Supposed to be the world's most active CNS drug. Primary was stable, but progressed in the bones. What is going on? So she's not happy. She's not driving. So we arranged a repeat percutaneous biopsy. We're not at the brain biopsy stage, of that lovely necrotic lesion. And actually on the second biopsy, she had an L858R EGFR variant. She still had the ALK, and some of what I'm putting up, I can't see the small print at the bottom, but really low sort of copy number. And probably in hindsight, it was subclonal, which is, I think, unusual for a fusion. But started her on osimertinib. She's responding. She's also got PIK3 kinase co-mutation. This doesn't feel like a really pure cancer for obvious reasons. So she's just started with chemotherapy with osimertinib. And this is another lady where if there's progression, I think liquid biopsy is going to be really important to understand, as we saw the evolution of her cancer and the clonal variants in time. So another one would be of a similar vein in the subclonal variety. This is a young guy I met to screen for a clinical trial. Again, he was diagnosed confidently a couple of years back with ALK, but started lorlatinib and progressed straight through and actually needed whole brain radiation at St. Elsewhere's. and so pivoted at that time to Empower 150 and had a good response. Into currently, he was rebiopsied after he'd had a couple of months on lorlatinib and went for CASP, and it's like it's a different human. This report we're seeing here, there is no ALK fusion. There are a lot of other variants listed there that, you know, make you wonder. But that was, you know, after he'd had sort of potent ALK inhibitor therapy. So he was good on chemoimmunotherapy. He had about 9 months benefit. He was progressing and symptomatic with central disease and in the liver when I met him late last year, but clinically deteriorating, getting chest infections, and it just all didn't make sense. He'd had NGS from another state, and I was sitting patiently waiting, but they didn't do RNA sequencing routinely. And about 400 phone calls later, it was actually easier to get him down and rebiopsy him in Sydney. So yes, pathology friends are good, but if they're in other places and you don't know them, harder to find. So we sent a liquid, we got on the phone to another state, because that's what we do, we agitate, and an NTRK fusion was called. At this point, I'm thinking WTF, but okay, let's go with it. Something's going on with this guy's biology and I don't know what it is. But then the tissue was cooking from the repeat biopsy, and the ALK fusion was detected again, but it was nicely prefaced and clear to the short attention span oncologist, low read count, like probably not driving this man's cancer. So I got on the phone about the liquid biopsy, and they'd been really ultra rich sequencing. Either way, it had been sequenced so much that unfortunately that was probably a false positive, the NTRK. So we prefaced that with a nil, and then we're trusting nothing at this stage. So we also did another complementary CGP panel, which concurred the ALK was in fact still there. The ALK IHC was positive, the ALK fish was positive, but this is not at the moment driving this man's cancer. So long story short is we still put him on the trial he came down for. He'd actually started it while we were trying to reconcile all this. It was a B7H3 antibody drug conjugate, which works for a multitude of issues, and a novel vaccine, and he's responding. So really interesting, because again, ALK made sense, but it just does not seem to be the driver of this man's cancer. Just a couple more cases to take us to time, but this is an important one about the advantage of liquid. So lung cancers are obviously generally symptomatic. This lady had an obstructing lung cancer and oligometastatic disease late last year. An FNA, a never smoker, reported pretty confidently a squamous cancer. Oh, sorry, not an FNA. Yeah, an FNA, bronchoscopic FNA, but insufficient tissue for molecular. And again, that lab sent into state. It took multiple weeks for us to know that. We're trying to work out what to do. No PD-L1 expression. Do I give her checkmate 9LA? Does this lady have an immunotherapy sensitive cancer? In the meantime, she was becoming very symptomatic and had urgent radiation. We sent a liquid biopsy, which had a nice turnaround time, and that picked up an EGFR exon 19 del TP53. We look at those ones with one eye. But so I've given her osimertinib and carbotaxol, like an abbreviated FLAURA2, and she's responding. So an important one, we discussed her case. We couldn't get more tissue. So liquid brought it through for her. Again, just a quick one, because immunotherapy is important, even though I'm a little biased to targeted therapy. But we see a lot of these cases, people that may have smoked, PD-L1 ZIT. We do a standard panel. We pick up a variant like a BRAF of, it is what it is, nothing we can action. This particular man had a family history of lung cancer, so we're starting to think a little bit more genomically inclined, but we sent him for a CASP, and he was a man that had an STK11 and some other variants there that aren't great for immunotherapy response, and that was really concordant, unfortunately, to this man's really brief immunotherapy period. So again, MTAP loss, I bring that up, and I've already alluded to the fact that even in, for example, this lady who had a RET fusion and a lot of other co-mutations as well, she went on to a trial. She had, chemo, unfortunately, was randomized first, but that's the trial. Went on to pralsetinib, really active RET inhibitor, but really minimal benefit. And unfortunately, for example, this lady who's got a fusion that should be exquisitely sensitive to, targeted therapy, but a lot of other noise and MTAP loss. At that time, MTAP trials were becoming available, but she was deteriorated quickly, unable to go on one. Now, my final two slides are our old friend RB1, which we did hear, unfortunately, is not good. And we're getting information about RB1 from our panels now. And in oncogenes, it can predict for small cell transformation. And at the start, there's not a whole host we can do about that. But this is a lady who was screened for aspiration as well with EGFR. She had an EGFR exon 19 del, but RB1. And I saw that at the time and I looked up the data and there wasn't any to give chemo up front. So she had osimertinib for a few years. She then had rampant progression in everywhere, including the pancreas. We could do a liquid biopsy at that time and picked up a lot of, potential resistance pathways, but liquid doesn't pick up small cell transformation, of course. So we biopsied her and it was in fact small cell transformation. Exon 19 deletion still present as expected. We pivoted this lady onto chemo and ADC. She had great reserve. We even tried tarlatamab. She did have some benefit from B7H3, but, at the small cell transformation point, she died within 12 months. So they're a really important group we've got to do better for. And then my final case is of the not everything is what it seems circumstance, is a man who crashed his car into his house, had a frontal lobe mass, had it resected. It was in small cell, slam dunk, went on to the first line tarlatamab Delphi 301 study, did pretty well, had a response. Chemo also works, but stayed on it for, I think, around 16 months. But I sent him also for CASP. He hadn't been a particularly heavy smoker. He had an EGFR exon 20 insertion. Okay, but, the small cell, again, is what trumps any of our treatments. But then he started to progress about 16 months in. As I said, miliary brain met's not easy. I did a biopsy then of the lung, and it was, in fact, adenocarcinoma, EGFR exon 20 insertion. Obviously, I'm still worried about the de novo small cell transformation this man had, but I've put him on the Papillon protocol with chemo and amivantamab. And amivantamab is really brain active, and he's had a good partial response also in the brain. So I think that's important. So my final two slides are on liquid and the unfortunate recent declining of liquid as an upfront test in lung cancer, which is a huge shame with MSAC and particularly the group that may have had legs being those that the first tissue biopsy is insufficient for. This is despite us being now behind the NHS, and they have really compelling pilot data of over 1,000 patients where they have very eloquently reported faster turnaround time, improved quality of life, improve lesser complications from tissue biopsy. And in fact, they've shown that the benefit to cost ratio is actually the best in those that have a liquid first approach with a significant saving to the healthcare sector. And I hope that we can continue to push this important application of liquid biopsy, because there is no doubt it's transformative for lung cancer. So those are my takeaways. I guess I've said it all and I've gone over time, but 50 Shades of Grey, and I put a politically correct or a PG picture up for that one, is really, I guess, how the molecular landscape can be, but obviously globally to the advantage of better patient care. So thank you for the time.